Hello and welcome to another lecture in the series of the APSA Fetal Committee's expert talks. The focus of this presentation will be prenatal diagnosis of abdominal masses. My name is Dr. Emily Partridge. I am a pediatric and fetal surgeon at the Children's Hospital of Philadelphia.
I'm Dr. Marisa Schwab. I'm a pediatric surgery fellow at Stanford.
So we'll begin with some preliminary considerations in the workup of prenatally diagnosed abdominal masses. These are typically first identified by ultrasonography, routinely at the time of the anatomic ultrasound, around 18 to 20 weeks gestation. And some of the initial considerations regard the characteristics of the mass, specifically whether the mass appears to be solid, cystic, or of mixed components. Other important considerations are the size, the location, and possible origin of the mass. In this regard, fetal MRI can sometimes be considered and can be helpful to provide additional characterization of the lesion. It's also important to consider the global assessment of the fetus, taking into consideration signs of other associated anomalies which might point to more complex or syndromic conditions. It's also important to assess for signs of fetal distress or hydrops, which may make prenatal intervention necessary. And finally, consideration should be given to referral to a fetal center for expert multidisciplinary consultation. We'll begin with considerations specific to solid masses. These are very rare findings, and it has been shown in some series that fetal MRI may be of additional assistance to characterize the tissue of origin or etiology of the lesion. The most common solid masses identified prenatally include neuroblastoma, renal masses, hepatoblastoma, and teratomas, such as sacrococcygeal teratoma. It's rare that fetal intervention is required, and indeed this is only considered if there are signs of obstruction of the mass or evidence of fetal distress, such as hydrops. In those cases, open fetal surgery may be considered to relieve the obstruction. In the realm of solid masses, those arising from the liver will most commonly represent hemangiomas, mesenchymal hamartomas, and hepatoblastoma. In the renal category of masses, congenital mesoblastic nephroma is the most common solid renal tumor seen in neonates, but consideration should be given to more rare etiologies such as Wilms, clear cell sarcoma, and malignant rhabdoid tumor. Mesoblastic nephromas have a characteristic appearance on ultrasound. They are large, heterogeneous, and solid masses with internal flow, usually appreciated on Doppler. Fortunately, these are largely benign masses with very rare malignant potential. They do warrant complete nephrectomy in the early postnatal period. Suprarenal masses carry a differential diagnosis which includes adrenal hemorrhage, which may be seen in as many as 2 in 1,000 live births, but could also represent neuroblastoma, as well as infradiaphragmatic extralobar pulmonary sequestration or adrenal or renal cysts. Typical management includes prenatal surveillance imaging with serial ultrasounds to monitor for size, echogenicity, and calcifications. And postnatally, follow-up imaging may include ultrasound and or MRI, as well as evaluation of urine catecholamines. Sacrococcygeal teratoma is the most common teratoma identified in the fetus. There is an over 50% mortality rate in cases diagnosed prenatally, whereas lesions which are small enough to escape prenatal detection tend to have an excellent prognosis. Both ultrasound and fetal MRI may help to determine the extent of the mass prenatally. CT may be of additional utility in the postnatal period, particularly with respect to the identification of intrapelvic and intra-abdominal extension, which can be important for surgical planning. Ultrasound features typically demonstrate solid and cystic components with areas of necrosis and echogenic foci from calcifications. The laboratory finding classically described is that of elevated AFP, and post-resection monitoring AFP is an important tool for surveillance and monitoring for recurrence. The treatment is complete surgical excision, including the coccyx. This is the definitive operation. However, in those rare cases in which hydrops, placental megaly, and significant fetal distress threaten fetal viability, operative debulking can be performed in an open manner during the pregnancy if indicated. Post resection chemotherapy may also be indicated if malignant elements are discovered on pathologic examination.
Cystic masses are actually very common. They're usually detected on the second or third trimester ultrasounds, and the differential is really wide. It can go from ovarian cysts, biliary or liver or splenic cysts, pancreatic cysts, mesenteric duplication cysts, as well as subdiaphragmatic pulmonary sequestration. What's really important to look at on the prenatal imaging is the size of the cyst, the location, whether there's any septations or internal echogenicity. But what's most important to convey during prenatal counseling is that malignancy in fetal cysts is extremely rare. And even if you see echogenicity or septations, that actually has a higher association with an in utero ovarian cyst torsion or other type of cyst torsion than actual malignancy. So in terms of the prenatal evaluation for cystic masses, serial prenatal ultrasounds are important because there is a risk of a bowel obstruction depending on what kind of cyst it is, polyhydramnios, and preterm labor. If the size is stable on ultrasound, then you could space it out to every 2 to 4 weeks. Fetal MRI may be helpful to characterize the pathology or etiology of the cyst, but in utero intervention in general for cystic masses is very uncommon. We recommend having the patient be seen at a tertiary center, given that you can have a neonatology and pediatric surgery consult prenatally, and especially in terms of determining what is the best delivery location for the patient. Postnatally, the evaluation usually begins with an X-ray and/or an abdominal ultrasound. CT, MRI, and nuclear medicine may be helpful adjuncts depending on what the pathology is thought to be. And surgical excision is needed for most of these lesions, but really the timing varies. It's rare to have an emergent need for operation for these cystic masses. Interestingly, the correlation between the prenatal and postnatal diagnosis is actually quite high, between 70 to 90%. Ovarian cysts are the most common type of prenatally diagnosed abdominal cysts. Postnatally, it's very unlikely for them to need urgent surgery, and actually unlikely to need surgery kind of less and less as time goes on. We're finding out if the cyst is greater than 4 to 6 centimeters on the postnatal ultrasound, you can consider drainage or laparoscopic resection to reduce the risk of ovarian torsion, but smaller cysts can typically be followed with serial ultrasounds. If they're enlarging or persistent or have any concerning ultrasound findings, that's when resection should be discussed. But it's really important to counsel families. There are excellent outcomes, including fertility preservation, even if the patient undergoes unilateral ovarian loss in the course of surgery. Enteric duplication cysts are also quite common. Typically on the ultrasound, you'll see these hypoechoic or anechoic structures with the gut signature, so the double-layered muscular rim, and some internal debris or hemorrhage can often be seen. Duplication cysts can occur anywhere along the GI tract, typically on the mesenteric border, but they're most frequently in the ileum, followed by the jejunum, and then the duodenum. About 50% of those diagnosed prenatally will become symptomatic early on in life and will lead to surgery. But if they're asymptomatic, you can watch them closely and then recommend a delayed prophylactic resection sometime in infancy. And that's the end of our presentation. Thank you.
Thank you very much.